Hi guys, good evening. It's me, Dr. Jenny Yusuf, physical therapist and doctor of physical therapy. It's another, thanks God, it's Thursday. So we have another innovator, physical therapist, academician, and entrepreneur. So every Thursday we interviewed and highlights our one of therapists, and now we have physical therapists. Before that, I want to introduce to whoever is not familiar with me. I'm Dr. Jenny. I'm a physical therapist and doctor of physical therapy and board certified clinical specialist in geriatrics. I'm the current vice chair of the Global Health in Aging Adults and also the founder of the Balance and Fall support group in aging adults. So tonight we're going to highlight and featured Dr. Chris Erickson. Dr. Chris Erickson is a physical therapist and doctor of physical therapy, and he is specialized in treating herniated discs. He is more on a manual physical therapist and orthopedic field, and he is specializing in that, giving a mentoring and coaching program. So if you have any question, you know somebody who has issues with herniated disc, low back pain, Dr. Chris Erickson is the man to go. All right, before further ado, he had 15 years of experience, more than 15 years as a physical therapist. And he's the CEO and founder, the president of the EHS, Physical Therapy and Chiropractic Clinic based in Iowa. All right, good evening, Dr. Chris Erickson. Welcome to PhysioGen PT and Wellness and Balance and Falls. How are you?
Thank you very much. I'm wonderful, Dr. Jenny. Thank you. Yeah, that was a great introduction. I appreciate that.
Yes, you are welcome. My pleasure. We are always fortunate to meet wonderful physical therapists in a small group we have in Facebook. We appreciate your time and in this moment that you're going to share your expertise to us. So tell us more about your physical therapy career. I say something about herniated disc. Why do you think you want that specific niche?
Yeah, great question. So, I initially, when I went to school, my undergraduate degree is athletic training, exercise science. I did not want to be a physical therapist. I thought that was a terrible job. I actually worked I was the head athletic trainer at a high school in Las Vegas. And during the summer, when school was out, then we had to work in the clinic. So I actually worked in a Health South clinic in Las Vegas. And that was right about the time when Health South, I don't know if you guys remember this, this is a while back. This had been the early 2002, 2003 timeframe when they got caught cooking their books and, fraudulently billing things. And so a lot of those clinics went out of business. And I was, in the clinic at the time, seeing that the physical therapists there were not doing really anything. They were kind of evaluating, they'd push it off to like athletic trainers like myself or a tech to do this stuff. Everybody was getting the same, cookbook, hot pack, hamstring stretch, E-stim ultrasound and out the door, and they're billing it. And so that's at that point I knew, okay, well, I felt like I could help people better and do a different, a better job than what they were doing at that clinic. I just didn't, I didn't like that model that they were prescribing to, where they would see, I don't know, it was a lot, 20, 30. And some of those places still exist today. Everybody hears those stories about going to the place where they, and the general public or our patients, our clients don't know that. And it's not their fault that they go to a place that, gives them the inappropriate or very, under valued care, where it's the cookbook, here's 10 exercises. Hope you get better. Good luck. Here's some hot pack and some hamstring stretches, and, go on the bike for 10 minutes. I'll come back and see you. Or they get a different clinician every time. So at that point, that's when I decided, yeah, okay, I'm going to go back to school. And so that's when I went back to school, came back to Iowa, went through the program, got my doctorate. And then from there, I have been working specifically in the outpatient orthopedic realm. So anything having to do with mechanical care, mechanical spine and mechanical pain in general. I went to New Mexico for a few years. So Eastern New Mexico in Carlsbad, learned under some very good therapists there and a man that owned a couple of clinics. I knew eventually that I wanted to own a clinic. So I took that job specifically to ask questions, to learn. And at that point is where I started to, get even more interested in the MDT model of assessment, and kind of an algorithm of, funneling down and figuring out, well, I can't treat and fix and help somebody that I don't understand what it is that they have. So I first have to figure out, what is this person? What do they have? Then we can go about figuring out a way to treat them. So 3 years down there in New Mexico, and then I've been back in the Omaha, Nebraska / Iowa area for the last 10 to 11 years. So
Wow.
as I got back here, that's when I kind of, started our own clinic. And I also believe in a multidisciplinary model. So we employ physical therapists and chiropractors. Because we do a lot of spine, it doesn't matter and that it really takes finding the right people who don't have an ego about their profession. There are still those that, will say, oh, chiropractic's terrible, don't go there. And then the other side says, no, PT is garbage, don't go to that. We don't have that in our employees, in our atmosphere. It's whatever you need more of. If you need more of A or more of B or somewhere in the middle, we don't care, as long as you feel like you're getting the care that you need, the service that you deserve, making the progress that you're supposed to, that you're paying us for. We don't care if they need more of, the chiropractic care or the PT care. And we also do some fitness, on the back end. We have wellness and fitness classes and small group training and one-on-one training as well. So that kind of takes us up to now.
Yeah, that's amazing. From athletic training, and then also you have your own practice right now. I really believe that whatever you see and you want to make a change, that really gives you an eye opening. Like, I need to do this because I'm seeing something is wrong there.
Yeah,
I wanted to give a
was
better.
bad stuff out there in Las Vegas. It was crazy.
Oh, so it's in Las Vegas. And I have also some colleagues in New York, like their style is like that's why I feel bad when they keep saying that physical therapy factory or something like that.
Mhm,
That,
mhm.
as you've said, multiple therapists, there will be one patient, there will be like a roll call, like a therapist
Yep,
A will see Mrs. Smith and then doing hot pack, or maybe like what you've said,
that's it.
electrical
Yeah.
stimulation, and they will be on patient B. And because the patient A
Mhm.
is done, but they will, so it's really better. As much as you can, we can give a better like one-on-one um service, and then wellness. And also I have some experience with chiropractic. My husband just had an accident, and then he needs a chiropractic, and knowing that physical therapists, we are doing some exercise and rehab, but chiro is will be more on the inside and some
Yeah.
manipulation correction. So that's really a different line there, and we need
Yeah.
their help in some ways. So that's good to
Yeah.
know.
We find a very good outcome with combining them. I think of it kind of as a force continuum. On the PT side, I'm always going to start with, patient generated, patient centered forces and movements. And then anywhere, all the way up into, so like, when you would know, Jenny, too, we kind of do some, different grade 1, grade 2, grade 3, like different kinds of mobilizations and
Yes.
overpressure and things like that. But the person who has the most, experience and hands-on skill at the very end of, or the high force, would be
Mhm.
chiropractic. So
Exactly.
many patients will say, yeah, I feel better, when I go. But then in the traditional chiropractic sense, usually they don't give them anything to do, in between or at home. So, I feel better when I go, but then a few days later, I kind of feel the same. Well, it's okay. Let's use the benefit of the chiropractic care and the adjustment. It feels good. It calms things down, gets the joint moving a little bit better. But then let's add, with what we do on the therapeutic exercise side, the therapeutic activities, on the strengthening, teaching them, you have a plan now for home to help this last longer, help speed the recovery. And that's where we kind of find the best, in our opinion, the best
Yes.
kind of combination of the two.
All right. Wonderful. So you have all your Mackenzie, athletic training. So if you were going to share some physical therapy CU courses or anything like program that influenced you a lot to be a better clinician right now in manual therapy and also in this herniated disc. So what are the courses or programs that influence you and influence you a lot and affects your practice right now that you can share
Oh
to
yeah.
these new clinicians?
Yeah, it's the new ones. I mean, the ones that, sorry, excuse me, something like, there we go. The ones that are most, to me, it was starting and taking that, McKenzie Part A and Part B course, just understanding and having, for me, it was really a paradigm shifting, experience of, wait a minute, like there are ways to understand, to basically a funnel of a algorithm and kind of, move things down to the bottom of the funnel and understand what somebody is. Are they, is it mechanical? Is it chemical? Do they need to be referred on to somebody else? Can we help them with, different repeated movements, end range, loads? Understanding, and that's the one thing that still bothers me, and you see it all the time, is and it's not clinicians in general, it's usually patients, but some clinicians say, well, yeah, we did, I did the McKenzie exercise. Well, you don't truly understand. McKenzie is not an exercise. It's a treatment and evaluation and assessment protocol. It's like the operating system for a computer. You can use any exercise within the system if it's just really knowing, what is the appropriate thing to do. So it doesn't, there's no like specific, McKenzie exercise, which is falsely or, commonly incorrectly associated with that assessment, technique of saying, well, you have to do, these press ups and you got to extend it. It's, just because that one is most commonly used, it just happens to be that it's commonly helpful. But I mean, any exercise, so all the other courses that you take in therapeutic exercise and other manual therapy techniques and dry needling and mobilizations, those all you can use. What's nice about MDT is you can pull all of those tools that you've learned in, and the key is you understand when to apply them. Like, okay, now I understand what this person is. They're deranged, they're dysfunctional, it's postural, it's mechanically unresponsive. You can understand what everybody is and what category they fall into. So when you subcategorize them, then you're much more. It's much more likely you'll choose the correct interventions rather than just guessing. Well, I'm going to do dry needling on everybody and just hope it works, or I'm going to do mobilization on everybody and just hope it works. It's knowing what exercises to use.
Exactly. And depends also on what case that happened to you, because there's specific position that makes you comfortable and
Yeah.
make it worse whenever you move on that angle.
Oh
So,
yeah, it's a lot of it is
so
understanding and
that's what
asking
you're
those
teaching.
questions. Mm-hmm.
Mm-hmm. So
Yeah.
regarding that, let's say we have a listeners right now in the Balance and Fall support group. Most probably they have family members, any back pain. Let's say it's not in any herniated disc related, but any low back pain. What will be your best advice to prevent any worsening back pain? So
Okay.
if you are just general advice to our listeners for caregivers and clients. Yeah.
Yeah. Yeah. So it's low back and neck are very common, especially low back. Probably the most, not probably, it is the most common complaint and pain in the U.S. It's also the most, costly in terms of not only dollars, spent on mechanical low back pain, but even lost wages, lost time. It is the most costly condition that we have is mechanical low back pain. It's very common. And so some of the things that they fall into patterns. And so many of the things that we try to work on that I found over the years that kind of fall into those patterns, especially with caregivers, helping older, maybe it's their parents, maybe it's they're just hired to help with them. So during transfers, during help with even with gait, with dressing, it's staying moving and staying active in all directions. We tend to overuse a lot of sitting and bending and flexing because that's just how our life works. we sleep, and then we get up, and then we sit to have breakfast, and then we sit in the car and we drive. And then a lot of us, sit in front of a computer, in front of a TV or looking down on a phone. And so those postures over time do tend to take a little bit of a toll. So getting up frequently, working on, because even just that sit to stand, just getting from the chair and up is a squat. So I mean, if someone tells you, oh, you should never squat, well, that's not true, because if you sit down and stand up, that's a squat. So getting up frequently, walking. I mean, even when you walk, you get slight hip extension, slight lumbar extension. Remember, the spine, mechanical spine pain is not well understood, as much as we like to think that we can diagnose things accurately from pictures and from subjective and objective assessment and history and all that kind of thing. Just general mechanical low back pain, where it just hurts in my back, and like Jenny said, it feels better when I do this, it feels worse when I do that. It's intermittent, it comes and goes. If I sit, if I stand, if I bend, that it's really, really difficult to tie that to a specific tissue. So really, it's just moving as much as possible in all directions. We get very sagittal. We move forward and backwards, and we rarely, as we age too, work in a lateral, so in the frontal plane, kind of walking side to side, or in rotation. So I like to give a little bit of, once we stand, a little bit of standing extension, so bending backwards when you first stand up, just to get those joints and tissues moving. They don't get good blood flow on their own. The discs between the vertebrae don't get good blood flow. They get their nutrition through movement and activity, which is why even if you sit in a good posture for long enough, your body will tell your brain, say, hey, I'm uncomfortable. You got to shift, you got to move, you got to stand up. And that's just that your body telling your brain, these tissues need oxygen. We need blood flow. So frequent moving around frequently, standing, extending backwards every once in a while. That actually help with balance too, because you've seen as people, they really tend to lean forward or lose their balance backwards after they sit for a lot. I remember
Yes.
helping some older folks up, and they just push backwards. They just can't get their nose over their toes and get their weight forward, because either it's fear or whether they're just not used to being up
Used
and
to it.
walking around.
Yeah.
And then working in the different planes of motion, laterally, rotation, and then using general fitness type things, squatting, deadlifting, push-ups, planks, all the things that have to do with keeping your core and lower half strong.
Yeah, that's really good tip. Very seldomly I hear that. I always advise them, keep moving, exercise is medicine, keep moving because it lessens your stiffness and this is better for your joint. But I like your explanation, Chris, that you need to move because that's how your blood flow. You need oxygen, and I like the word nutrients. I didn't think of explaining that to my clients. I just it's really simple, but that's really very good keywords. Like you need to move because that's how they get the nutrients, the oxygen, the blood flow. I know the oxygen carries the blood, and the blood flow carries the oxygen to the joints. But I like the nutrient itself. When they understand what's going on, they will have a better compliance. I explained that. That's why it's really good keywords there. Thank you for sharing that. So you shared already for the clients. How about the clinicians that you want us to always include definitely some of the tips in your experience that whenever you do this, you see a better progress in a specific low back pain?
Okay.
Although it's
So
many factors, right?
yeah, no, it is. It is. I mean, obviously, just practice. I mean, you got to see a lot of spines. I mean, you got to keep practicing, you got to keep an open mind. The one thing that even I do, and I have to continue to go back to, courses and go through the process, is we tend to see these patterns and then we start jumping on bandwagons like, oh, I've seen this before, I know what that is. But stay true to the process, and always, like, especially in the neck, shoulder, arm, have to always at least consider that any kind of shoulder or arm pain could be lower cervical related. I can't tell you the number of people that come in that say, my shoulder hurts. Okay, what'd you do? Oh, they did, I did a bunch of these and a bunch of these. And Well, okay, tell me more about it. Like, where did it start? How did it happen? And then eventually, as you get digging a little bit further, oh yeah, when it does hurt, it's on the trap and it's down on my shoulder blade. And when it's bad, I can't turn this way. Okay, as soon as you start assessing the lower cervical spine or upper thoracic, all of a sudden, arm is moving. Oh, yep, it's gone. Arm pain's gone. But if you fall into that trap of zeroing in, and looking just where that initial complaint is, which is what happens with a lot of family practice doctors. And I have a lady that I just am helping tomorrow, actually. I talked to her on the phone last night. 6 months at least. Yeah, it's been like 6 months. Shoulder pain, right? Right arm, started in the trap, shoulder down the arm to the thumb versus, these 3 fingers. But goes to the general practitioner and says, my shoulder hurts. So didn't ask many more questions. Because she's over 40, it's her dominant arm, and she was like very active with things. If she lives on a farm, played sports, she has a bit of a. So they went. What do they do? Okay, directly to the MRI. Okay, so now you're going down a slippery slope or a spiral. You're basically looking for something, a confirmation bias, to prove what you think is going on. Now you see a slight labral tear in the back, and she goes, gets injections, goes for 6 weeks of therapy. Are you any better? No, I'm not any better. Okay. Well, why? Like, what did they do? Oh, they had me do all this. They had me do all this. Did anybody check your neck out? No, nobody checked my neck out. And so you just assess the neck a little bit, start moving around. Like, oh yeah, the arm feels a lot better. So she wasted all that time, all that money, and they weren't even on the right spot. Now the bad part is, if no one catches that, and she goes back to an orthopedic surgeon, and again, zeroing in on this kind of odd, arm pain. Oh, I have arm pain. I have an MRI that says I have a little bit of a tear, which is not uncommon in a 45-year-old person that's active. She gets a surgery, and then she's no better. There's $30,000 wasted on a surgery. And now this is not all the time, but I mean, these things do happen. So my point is,
Yes.
when you're looking at things, always it is worth the 5 minutes to us, even if it's a knee pain, even if it's a calf pain. Like, it looks all the world like, oh, they just had an ankle sprain, or they got a heel, an Achilles tendon pain, or they got plantar fasciitis. I will catch every once in a while, 1 out of 15, 1 out of 20, that if you assess the lumbar spine, takes 5 minutes, just move them all the way forward, like really flex them, really extend them, really, just get to end range and load it. All of a sudden, be like, yeah, my foot feels different. That's funny. It's okay. It's not anything to do with the foot at all. So the key, I believe, is make sure that you take at least 5 minutes and assess the lumbar for anything, hip and down, and assess the cervical and upper thoracic for anything shoulder and arm related. I mean, I've seen like, again, all the world, like, oh, it's definitely a tennis elbow, pain with gripping, weakness with wrist extension, all the things. And they treat it like a tennis elbow, no better. All of a sudden you look at the neck, start moving them around, and they're like, oh yeah, my it's stronger. I don't have the pain anymore. I mean, that's probably 3 out of 10. So it's too high of a percentage to not at least, and it's our job to do that due diligence. We have the time to spend more time and dig deeper, more questions, more objective testing than they do in the physician's office. They get 7 to 10 minutes, in the office, and they'll write them a script. Yeah, they'll give them, here's some medicine, here's a referral for PT, come back if it doesn't work. And then if we don't do our job and actually, fully assess that, we can't just go off of, well, it said tennis elbow on the script, so I guess I better, put the ultrasound on there and do the bands. Like, okay, use your brain, like, look back, ask more questions, what's really going on here.
Yeah, I totally agree with that. It's anatomy trained. So it's really like it's just the same exactly as how you described, like the patient has low back pain. And then when you're going to check all from the ankle to the knee, and then you will really see that the origin is from the ankle, and that's how he walked. That's why it's a referred pain coming in the center, and exactly from the neck. And that's history taking. We should be a really good history taker, because one big question, and that's the root for everything. And I agree, it's just so hard for the physician and then they're in a hurry or very, it depends also on the how they question, you know. So
Mhm.
the patient will just answer on what they question, and they have limitation on that. Unlike us, we always see them more than 45 minutes, so bear on all those like question is really the key, you know. And
Yeah.
thus they have more freedom of questioning, like, oh, I did this one time 2 weeks ago, I just have a little bit of trip, but I know it's not related. But that's the key. You trip
Mhm.
and then
It,
accidentally do
it
that, and
might
he
it might
didn't
be
think
related.
about that.
Right.
Hmm.
Yep.
And that is, they always think those simple things, but after 2 weeks, that's everything. That's how begins, you know. So those are really wonderful tips, Chris. And I hope that we can learn more from you. So how can we connect with you, to our listeners who has lots of questions?
Sure, sure. I mean, they can always reach out via direct messenger. I do have a Facebook group, the
Yeah.
fitness and exercise routines for herniated disc injuries. I can always just come on even my personal page. There's an Instagram channel, herniated disc fix. I'm working on getting a couple of other different things going with that, but yeah, those are the easiest ways to get a hold of me. I try to be as consistent as possible on social media, try to,
Mhm.
bring as much value as possible with frequent little tips and live videos, and trying to exercise, rehab tips, I guess. So those would be the
Yes.
easiest ways.
Yes, and your TikTok, the one that's really good, and your
Yep. I'm
YouTube.
not
So
afraid to dance on TikTok. I'll do all that. That doesn't bother me at all.
those are wonderful educational videos, and you always correlate the different movements to a functional, and that's really really important, because oh, that's really what I usually do, and why does this particular exercise is beneficial in my day-to-day activities, you know. So that's
Mhm.
really important how they correlates those in their daily function. Thank you so much, Chris. I know that our time is so short, but we always learn from you, and we will try to connect with you. So guys, if you have any questions so far, just always connect with Chris. So last note or last questions for us, Chris, do you have any message for our listeners, our clinicians? Any message?
Yeah, I mean, I think it's very important what you're doing, especially with the older population. I mean, I know it as I get I'm into my 40s, and I have a lot of clients. One of the people that I like to help the most are those, 40, 50-year-old people that are finally starting to see the edge, the corner, and say, you know what? I don't care as much anymore about, certain metrics of like, oh, I need to lift so many pounds like I used to when I was 25. Now I just want to be as fit, as strong, as healthy as possible. I want to live a long time, be as functional as I can as I age. As you go into life a little further, you can kind of see where there are people, those that are 75, 80, who have taken care of themselves, who move well, who are tall, who have good balance. They take good long strides, that, they look, sturdy and healthy. And some that are, 60 and like, oh, and they're all beat down, and they don't move well. And a lot of that even comes from, and I've learned this just over time now, is, mental mindset. If you believe that I can do this, I'm strong, I'm going to stick with it, I'm going to live a long life and healthy, as opposed to, oh, I'm old, and, I'm broken down, and this hurts, and everything's bad, when you tell yourself those things, and that mindset is positive versus negative, it absolutely affects the physical part of the body, even though it's, like say cognitive and mental as opposed to physical, but it does transfer over into how your body moves and how you live.
Exactly. Exactly. Mind over body or mind over matter. It's always something that whatever you think will happen. I keep telling that to your page. All right,
Yeah.
I will fall, Jenny. I will fall. All right. If you say you will fall,
Yeah.
definitely you will fall. You
It's
say
a
that
it's a
already?
self-fulfilling prophecy. You'll find a way to fulfill what
It's,
it's a self-fulfilling prophecy. If you say,
yeah.
I'm going to fall for sure, you'll find a way to fall. And if you're like,
Yeah,
no, I'm
because
going to
that's
do
what you
this, I'm going
said.
to work on this, I'm not going to fall, I'm going to get
Mm-hmm.
better balance, then you'll find a way. Your brain just looks for things to find to prove yourself right.
Yes, and you tell that already to your mind. The mind will just tell to the motor and to the sensory and to
Mhm.
the body, okay, I need to move the way I need to fall, because that's what
Yep.
I just heard. right?
Yep.
And then I will
It's all
react.
this.
And then everything psychologically, now the anxiety level will kick in and everything. So doesn't help, which is really important for us physical therapists. Sometimes we always be there like a coach and also a psychologist, knowing what are their fears, and we
Yep.
are there as their coach and also a boot like to boost their minds and also
Mhm.
their energy, their confidence. So once we have that, that will be everything will follow. We need always to open that fear. That way we can correlate with the patient, because we keep coming there and you still didn't dig in. Where's the fear coming from? What's really the problem? You just keep doing exercise, but definitely you still didn't get the idea of the patient, right? So there's something missing. We always need to see that as well whenever we do an exercise, a visit. Psychologists, sometimes we're also psychologists because we are everything. We are a teacher, educator, a coach, everything. So we are really thankful with all your tips, Chris, and also your ideas. These are all very, very important in our daily lives. So, do you have any questions, guys? If you have any questions, connect with us. And also, we will going to post Chris emails or contacts. He is in YouTube, his social media, and congratulations on your Facebook group. So check on that and join with Chris. And thank you so much. So again, thank you so much, Dr. Chris. Thank you, guys. So it's me again, Dr. Jenny Yusuf, physical therapist and doctor of physical therapy. If you have any questions, connect with us. Thank you so much for listening to all the Philippines people in Philippines, good morning, and also in United Arab Emirates, Saudi Arabia. Salam alaikum, guys.
Assalamu
Ramadan
alaikum.
Kareem. Yes,
Mhm.
Ramadan Kareem. Ramadan is coming soon, so thank you so
Yeah,
much,
Friday
guys.
starts Friday.
Yes. Oh, he's really aware. Thank you. So good luck, guys, and have a great day. Thank you so much, Dr. Chris. Have a great day.